So I can see we have Nefas from Japaigo. Can you hear us? Okay, I think we can. Mr. Jim Yunda, can you hear us? Anyway, I know we have Dr. Maria. I hope you can hear us, Dr. Maria. And Albert, we already checked. Is it 2:30? Okay. So it's 2:30. Good afternoon, everyone. Before we go into our presentation today, we would like the spokes to introduce themselves. We'll start with Senanga. Somebody to introduce the team. Okay, that's fine. Petauke, can somebody introduce the team from Petauke?
Hello, good afternoon, sir.
Good afternoon, how are you?
Fine, thank you. Oh, no, I'm feeling much better.
Oh, okay. I'm sorry, is that Petauke? Okay, we'll move on to Choma. Choma, can you hear us?
Yes, we can.
Okay, and we can hear you very well. Chipata Central, somebody to introduce the team and themselves. Please unmute Chipata. Chipata, somebody to introduce themselves and the team.
Good afternoon, Dr. Foloshi. Good afternoon. Can you hear us?
We can hear you very well.
All right. My name is Dr. Mpeta Chipata, joining the Chipata team. Dr. Matua, the HIV mentor for Fubui and Jadiza. The rest of the team, we don't know where they are, but they will be joining soon, I'm sure.
Thank you so much, Dr. Mpeta, for sparking that spoke. So my work in Chipata will be way less. Lewanika, can somebody introduce themselves with the team?
We are here, but I'm still waiting for my colleagues. They're running late.
Okay, you can introduce yourself. It's fine.
Chipomwela.
Okay, thank you very much for joining us. Livingston, somebody to introduce themselves with the team? Hi, Robert, is that you? Yeah, that's Robert, clinical mentor. I'm so sorry, Robert, we actually cannot hear you, but I hope you can hear us. And then, Chilenge, good afternoon. Somebody to introduce the team? Chilenge, can you hear us? Kindly wave if you can hear us, Chilenge. Perfect. Are you able to introduce yourselves? Okay, so we'll now move on to the individuals. Hi, Lucy, you are welcome. Are you able to introduce yourself? Hi, Lucy, can you hear us?
Yes, okay. I can hear you.
Okay. Are you able to introduce yourself?
I'm Lucy Zulu, Technical Officer TB HIV/CT from Japai.
Okay, thank you. We'll move on to Jim Muyunda. Mr. Muyunda, are you able to introduce yourself?
Yes, please. Thank you, Chair. My name is George Muyunda from Japaigo, responsible for strategic information and technology.
Thank you, George, for joining us. We'll move on to Doug. Doug, good afternoon. Are you able to introduce yourself?
Oh, hi. This is Doug Watson calling in from Toronto.
Thanks, Doug. We appreciate your presence. Hi, Robert. I see you've joined us from a mobile. Are you able to hear us now? Okay, he's over there. Oh, we've been joined by Mongo Urban. Mongo, is somebody able to introduce the team? If you can hear us. Okay, perfect.
We are able to hear you loud and clear. And Sylvia joining you from Monk Urban. With me, I have nurses and students.
Thank you very much, Sylvia. Dr. Maria, can you hear us? Okay.
Hi, good afternoon. I can hear you loud and clear.
Okay, are you able to introduce yourself?
Morning, good afternoon, sorry. Dr. Maria from the Pediatric Center of Medical Officer in the ARC Clinic.
Thank you for joining us, Maria. Nefas from Japaigo, are you able to introduce yourself? Hi, Nefas. Are you able to introduce yourself?
Good afternoon.
Good afternoon.
My name is Nefas Hindamu from Japaigo. I'm a knowledge management and communication specialist.
Oh, thank you for joining us.
Thank you.
Makando, are you able to introduce yourself?
Hi, hello. I'm Makando from Japaigo. I'm providing the IT backstop.
Thank you, Makando. Joel, are you able to introduce yourself?
Hello, good afternoon. Joel Muviana, clinical mentor from Lovezi.
Thank you for joining us, Joel, all the way from Lovezi. I see you've been joined by Dr. Mlenga. Are you able to introduce yourself?
Hi, Dr. Foloshi. I'm Lloyd Mlenga from UTH and MOH.
Okay. Thank you all for joining us. So today at the Hub, we have a team from HW21. We have people from CDC. We have people from the Adult Center of Excellence, people from Pediatric Center of Excellence, and people from next door, because I asked them where they're from. They just said they're from next door. And of course, we have the very supportive ID team with us to help us with everything. And this is Sombo. I've just realized, Dr. Mango, I didn't introduce you. Sorry. How are you, Dr. Mango?
I'm fine, thank you. How are you, Sombo?
I'm okay, thank you. So we'll move on to the case. Today we're starting with the case just to mix it up a bit. Edgar, you're able to pick up the case first, introduce yourself and your team, then go into the case.
Thank you. With me here, there is a team of people from ART, the TB clinic, and also the nearby clinic where the case is coming from. Then we have also the medical superintendent for the hospital, Dr. Shawa.
Okay, thank you very much for that, Edgar. So to help us with the case, we have Dr. Monica Kapasa, who will also move on into a didactic presentation. But we also have Dr. Thomas and Dr. Rokaya here with us. So please go ahead.
Thanks so much. Yeah, so the history of the case, it's the case is a 10-year-old female, HIV diagnosed in 2015. By that time, she was aged 7 years when she presented with oral thrush that was treated with Nystatin. The patient was initiated a month later on ADC, 3TC, and Nevirapine, then later switched to 3TC and heparins. The patient was since December 2023, with cough on and off, occasional fevers, and also there was some weight loss. Then in June 2018, sputum was sent to the lab and gene expert was positive. There was no rifampicin resistance detected. I proceed?
Yes, Edgar.
Then we come to ART initiation journey. On 26th of September 2015, the event was diagnosis of HIV, then action taken, referred on mothers and enrollment on ART at the nearby clinic. Then on 1st October 2015, the patient presented with oral thrush. Are you getting me?
Yes, Edgar, we may have lost you. If you can just read what the action was in October 2015 when she presented with oral thrush.
Yeah, the action was the patient was given flucloxamine or tamoxifeno, injected, then recommended for a speech assessment. Then on 15th of the same month, same year, a spirit assessed and treatment preparation. Then continued treatment on prophylaxis. Then on 27th of October 2015, a spirit and treatment preparation was completed. The patient was initiated on ART. Then on physical examination, the weight for the patient was 27 kg. Then 3 months before, the weight was 25 kg. Height was 133 centimeters. Then respiration 22 breaths per minute. Heart rate was 71 beats per minute. Available results: CD4 baseline was 500 cells per milliliter, that is 23%, which was done on 15th of October 2015. Then on 28th August 2016, the CD4 cells, it was 701. Then on 50 or 50 December 2017, the CD4 rose up to 1,275. On 5th December, the same year, HB was 10.7. Then on the same date, ALT was 31.7. Then the following year, that is on June 16th, Gene Expert was positive. Then on 8th August and on 8th October, the same year, follow-up smears were done and they were all negative.
Hi, Edgar. So just, are you able to go a step backwards in your slides? We just wanted to get an opinion with from our spokes. Material level 1, I see you've joined us. You are welcome. Are you able to introduce yourselves?
Yes, Dr. Katamba Chiwangu here with the team from Material Level 1 Hospital. Thank you.
Hi, Chiwangu. So we are just trying to get an opinion from the spokes. What do we think is going on somewhere in June 2016? What would be the appropriate action? What are we thinking is going on with this patient? So anyone from the spokes can give us their contribution. Edgar, are you able to go a step backwards, please? Again? Again? Just the first, the history. Yeah. So when this diagnosis was made in 2018, what are our thoughts? What's going on with this child? Anyone from the spokes to assist us? Peter, okay, good afternoon. I've seen you've joined us. Are you able to introduce yourselves?
Yes, good afternoon.
Good afternoon.
Yes, Dr. Kabala Bill here online with the team from Petauke.
Hi, Bill. Well done for joining us. Does anyone from the team want to contribute what was going on in June 2018 with this child who was on the back of a 3TC and efavirenz? Oh, Chipata, please go ahead if you have a contribution on what was going on with this child. By then, she was 7 years old, I believe, when this diagnosis was made. Chipata, any comments, contributions?
have unmuted us. So.
Oh yes, Dr. Mpetan team, please go ahead and contribute.
Yes, we're waiting for Dr. Matua. Any thoughts, Doc? What happened with this child in 2018?
What happened, I don't know, but the only thing I'm seeing why the regiment was changed from the one with nevirapine to efavirenz.
Mm-hmm. But in 2012, this child presented with TB. TB, yes. The gene expert was positive.
That is
2018. Yes.
Mm-hmm. But he was initiated in 2015.
Yes. So what is happening to this child? That's what we are trying to. So there are a number of possibilities in this child. This is a 10-year-old and female at that period, which is quite, delicate when it comes to compliance to medicine. So first of all, we have to understand, why has this child developed TB? Was there a positive contact at home? If not, is this child failing treatment? All right. And if this child is failing treatment, why is the child failing treatment? At that age, basically, in terms of the weight band issues should be constant. So we have to look at the issues of compliance. Is this child compliant to medication? Is this child being monitored when they are taking, this medicine? Is this child having any other condition that can affect the taking of medicines or even adequate exposure, including chronic diarrhea? So those are some of the issues that we need to interrogate.
I agree with you, Dr. Mpekta. Thank you very much. We'll move on to the hub. Any concerns, contributions about this patient at this point? Yes, Sister Phoebe.
I would like to find out who is staying with the child. Is it the biological parents or just other guardians?
Edgar, you heard the question, right?
Sorry?
We want to find out who is staying with this child because we have to establish about adherence. Is she staying with the biological parents or just some other guardians?
Biological mother.
Okay. With the mother who's HIV positive and on ART. I can't see that. And any siblings?
She has 2 siblings who are 17 years old, but they are all negative. Then maybe let me also mention that the mother in 2017 had also become positive.
Say that again, Edgar.
She stays with 2 siblings who are twins, aged 17 years. They are all HIV negative. Then let me also mention that the mother in 2017 had sputum positive TB, which was successfully treated.
There you go. Okay. Thank you very much, Edgar. That's very helpful. I think someone wanted. Zico, please go ahead.
You mentioned that this patient presented with respiratory and constitutional symptoms in 2017 December, but the diagnosis of tuberculosis was only made in that 6 months later. What was done in that 6 months prior to the diagnosis?
So what was going on in those 6 months? Why do we have a 6-month delay in making a TB diagnosis in this 7-year-old? Do you have a response for us? Edgar, I know you just met the patient.
Okay, when we go to action, can I scroll down to actions?
Yes, sir.
Okay, I think it was missed out. The only thing which was done was just the symptomatic treatment of the fevers and the cough.
Oh, I see. Okay, is that okay, Dr. Sivile? I don't know, maybe we can let Dr. Kapasa comment. Is that common and unusual to have that type of a delay in making a diagnosis of TB?
we're actually seeing it in a lot of health facilities, because I think people are having challenges with making diagnosis of TB in children. We did, I think, pass a bit of time, 6 months. I mean, we have even treated presumptively, depending on the basic investigations that were done, because I think this TB was started only when the gene expert was positive, but we could have made a presumptive diagnosis of TB depending on what the symptoms were and what basic investigations we did. If we had an X-ray, and given that the mother had a positive, had sputum positive, is a very big risk factor for this child with HIV. So yeah, I think it's challenges in making diagnosis. Maybe they wanted to get a sputum, but we could have gone with clinical symptomatology.
Okay, thank you very much for that. Dr. Boyd?
So I have a question. So this child was diagnosed with HIV in 2015, and I'm wondering if the child was ever started on INH prophylaxis, and also when it was realized that the child had a contact who actually had active TB, was it considered even at that point?
So Edgar, you got the question, right?
Yes, I did.
Mm-hmm.
Yeah, the patient was started on IP10, although the dates are not clearly recorded prior to the contact. That is the mother who the child was with.
So the patient was started on isoniazid or Ceftriaxone, Edgar?
Isoniazid.
Okay, so this child got TB while on isoniazid?
Yeah, she got while she was still on isoniazid.
Okay, that's a breakthrough TB, I guess. Any other comments from the spokes? I think Chipata has a question. Please go ahead, Chipata, with your contribution. Chipata, we are ready for your question.
Is it going on?
It's not. Just speak now.
Dr. Matuaye, the HIV lead mentor. Our question is that the child in 2015 was initiated on Abacavir, TTC, and nevirapine. Then later on, they switched to efavirenz. They just switched nevirapine to efavirenz. Would like to know why the switch was done, and was it a good alternative drug to switch on?
Okay, thanks a lot.
The child was switched to nevirapine because she had the problems with the skin. She had skin rashes.
Please speak up, Sister Teresa. Sister Teresa, please speak up.
She had problem with the rashes.
Oh, so she developed a rash on nevirapine. That's why they made a substitution from nevirapine to efavirenz, which was somehow a good thing because she ended up on ATT. Anything else? Pata, please go ahead.
It's okay.
Sorry? It's okay. It's okay, it's understood, I think.
Dr. Mwemba, please go ahead with your question. I've lost my screen and everyone's screen.
Thank you so much. I don't
Thank you, Dr. Mwemba.
I have two questions. I just wanted to find out what's the current weight for the...
What's the current weight, Edgar, for this child?
And then also I wanted to know what's the viral load.
Okay, so Edgar, what's the current weight for our child and what's the viral load?
And then if I remember very well, in 2015, I think the guideline then was that probably efavirenz was a preferred drug here than nevirapine. And I think that probably that could have been the reason for that switch.
Okay, because, okay. Edgar, people want to know what's the viral load for this child?
Viral load was not done, but the current weight is 27 kg.
Okay, thank you very much for that. Any other contribution? There's also a contribution that maybe in 2015, the preferred drug was actually efavirenz. So aside the rash, I would like you to go back a bit, Edgar, to your patient journey, where you talk about the ART initiation, where there was linkage to a local clinic, then the child came back. That's a whole month we lost there. Your next slide, please. Oh, yes, I don't know. Maybe Dr. Rokaya or Dr. Thomas can help us with this. Is this a typical patient journey? Is this what we recommend? Because there's a 1 month delay to the time the child actually ends up on ART.
I think by 2015, we had already moved on for pediatric patients to treat everyone who tests positive. So it looks like there was quite a long delay in initiation for this child. I don't know what treatment preparations were going on, and there was movement from one clinic to another. Maybe they were still in denial or something, but there was a long delay in initiating.
Okay, thank you very much, Dr. Rokaya. Is it okay if we move to your questions, Edgar?
Yes. So our question is, what would be the best ART for this girl? Then we want also maybe to have a comment if we can transition the girl to TLD.
Okay, so before Dr. Kapasa answers the first question and Dr. Mwango and Dr. Sivile tackle the second question, I would just like to summarize this child. 10 years old, female, HIV diagnosed at the age of 7, clinical course complicated by the development of TB, likely contact or smear positive mother. ART was initiated a month after diagnosis on abacavir 3TC nevirapine, had a substitution from nevirapine to efavirenz, so current ART is abacavir 3TC with efavirenz. Child seems to have done well on the ATT. Initially was smear positive. 3 months later, smear was negative, has gained some weight, is now 27 kg from a baseline of 25 kg. So about to complete the ART, I think I'm a month to finishing. So she's on rifampicin, isoniazid, which I think she's got a month to go. She's on abacavir 3TC efavirenz. And her CD4 actually has shown some impressive leaps and bounds. She moved from 500 to something like 1,275. So at this point, as they plan to go off the ATT, what would be the best ART for this girl? Oh, Joel, just as we are preparing to answer that, Joel, please go ahead. I'm sorry, Joel, we can't hear you. Just a second. Joel, please go ahead. Start again, sorry. I think something has happened to your sound, Joel. We could hear you very well, but now we can't. We can't. Okay, I'm sorry, Joel, we can't hear you at all. So maybe from our spokes, is there any contribution on what would be the best ART for this 10-year-old who's on abacavir 3TC efavirenz and 2 FTCs? Chilenge, please go ahead. They are waving. I'm sorry, I can see you now. Chilenge, please go ahead with your suggestion and contribution. Are you able to move closer to the microphone? I'm so sorry, Chilenge. Are you able to type? Just use the chat box for typing. I think even you, Joel, just type in the chat box and we'll read them out. I'm really sorry about that. There's a question from Senanga. Please go ahead. There are questions from Senanga. This is a good case. Senanga, please go ahead with your contributions. The problem is here. I'm so sorry, Senanga. Please just type in the chat box as well, your contributions or your questions. Okay. So there were issues that were brought out in terms of what is the adherence. I'm not sure, Dr. Kapas, how important is appropriate dosing in the pediatric population?
It is very important. We give medication to children based on the weight, and so it's important that each time we are reviewing them, we are noting the weight and we adjust the medications appropriately according to the weight, because that would impact on the response to treatment if we are not giving medication according to the weight. So it's important, yes, that we are checking the weight and give appropriate dosing of medication based on the weight.
Okay, thank you very much for that. So any suggestions from the hub on what would be the best ART for this girl? What would be the best ART?
May I ask a question? So this case so far has been presented as a case of a child that's doing well.
Yes.
So I'd like to understand what is the rationale behind their question.
Edgar, hi.
Hi, Doctor.
Hi, there's a question as to why you're asking your question. Why are you asking this question?
We're missing, because what you've told us is that immunologically she's doing well, right? So CD4 count was 500, that's now 1200. And the only thing we don't know is virologically how she's doing. And I'm assuming you haven't told us anything clinically that suggests she's not doing well. Mm-hmm. So I'm just trying to understand.
So my only concern was that she gained from 25 to 27.
Yes.
In 2 years.
2 months.
2 months.
2 years.
And then I wanted for the 2 months. Is it 2 months or 2 years? 2 months. Before starting
in 6 months. Been on ART since June.
For 6 months. So that's 6 months. I wanted to find out
in 6 months.
What's a weight gain for in a child who's this small and then they gain only 2 kgs. Is that a good response? And then secondly, is that what's the expected weight at that age?
A percentile, like what
yeah.
percentile?
Yeah. So maybe before they respond.
Maybe that can help us.
Yeah. Obviously, she's underweight. The expected for this 10-year-old, we should be talking about between 30 and 33 kilos. But I think what we don't know is the social circumstances of this child. So we don't know what the social, so maybe that can impact on, her weight gain if she's not nutritionally supported, which is usually required in a child who has TB and HIV. So we need to know about the social circumstances of this child.
Baseline weights.
Yeah, and the baseline weights, where we are coming from. Because this note is saying she was 25 kgs 3 months prior to commencing ATT, and she's on ATT for like 5 months. Yeah. So that's like 8 months. She's only gained 2 kilos. Yeah. So we need to understand what the baseline weight and what the socio-economic circumstances are.
Dr. Ziko Shilenja has a question. Please go ahead. There's a question. You can read it for me. Okay.
Let me read it. You won't be able to see. As we all know, the sensitivity of the smear is low compared to GeneXpert MTB-RIF, and this results in late TB diagnosis in facilities where GeneXpert is missing. Are encouraging TB management based on clinical diagnosis?
So the question is, are you encouraging management of TB based on clinical, because not everyone can have GeneXpert? And the sensitivity of the smear, which they have access to, may not pick up a TB.
I mean, yes, and depends on the circumstances where you are. If you have access to, GeneXpert or a smear, it's encouraged, because we need to have bacteriological confirmation anyway. But in situations where you don't have, you'll have to go with the symptomatology and the contact and whatever, maybe radiological examinations that you are able to do. So yes, you can go on, you can start presumptive TB treatment based on the symptoms, and the radiological findings if you don't have access to bacteriological examination.
Sorry, before Dr. Zico just asked a question, I think we haven't answered one question.
Just in addition to what she said.
Yes.
In addition to that, apart from the radiological and the symptomatology, you can also start treatment based on response or non-response to antibiotics. So if a patient comes and you put them on antibiotics without any response, then it would be justified to put them on ATT while you try to investigate further.
Okay, yes. So in the absence of a smear or a gene expert, if the clinical history is strongly suggestive, you are better off treating, because mortality from TB is very high, especially among the pediatric population. And there's also risk of progression to TB meningitis, which has a lot of disabling sequelae. The question to you, Edgar, is why are you asking us this question? What is the rationale? I think there was a question like that.
Thanks a lot. I think the team has noticed that the weight was not, I believe there was weight gain, it was not sufficient. Then also, the patient was put on the same regime, which she's still taking now. Then she developed TB in the process, despite being put on isoniazid. So we are thinking maybe there's something better we can do for the patient.
Hi, Edgar, I like your question, isn't it? So there is insufficient weight gain, and despite that CD4 count, the child doesn't got TB, it could suggest treatment failure. So that's why they were asking that question, because how reliable are CD4 counts in children? Well, I know she's a 10-year-old. How should we interpret CD4 counts in children?
Well, I mean, now I think we've moved to virological monitoring, isn't it, as a way of assessing how well the child is doing. So, I mean, like somebody asked earlier, it would have been nice to have what the baseline and the subsequent viral load was, because we can see that from the CD4 she's doing quite well. So, yeah.
So one of the recommendations, you have it there, Edgar, is that we should do a viral load, and that's what will help us determine which ART this child should get. For now, since we have a good CD4 count, maybe we do the viral load, then we can advise. So what would be the best ART for this girl?
So she's still, I mean, now she's on efavirenz, isn't it?
Yes.
The NRT and which is okay for this age group, and the fact that she has TB. So I would continue her on this, and then like we are saying, maybe we need to do a little bit more monitoring of the viral load and see where you. I think the question now will come in after she completes the ATT, and the fact that now she's going beyond 10 years. So that's when now we need to consider which other medication will, in terms of the ART, would move her to, I suppose, the PCOE and the infectious would help. But I would think that giving her, the same NRTI she's on, and probably a protease inhibitor like lopinavir, ritonavir, she's going beyond 10, I suppose, would be appropriate. I would admit her comments from.
Any comments, Dr. Kaya, for this child? Before we get a viral load, should we keep her on this? Should we give her TLE? Should we give her PI?
I would okay, let me give you my opinion on this case. I think this is a stable patient doing fine on ART, looking at the CD4 minus viral load. She got the TB because she had the contact with the mother. And the weight gain, I think, is sufficient. To put on 3 kgs in 6 months is not too bad. And so I feel like she just got TB as any HIV patient is vulnerable to getting TB. And in terms of management, I would continue with what she's on, ABC3TC efavirenz for now, because it looks like it could be working. If we get a viral load, we may want to then reconsider if she's failing then. But for now, I would maintain that I wouldn't be going to PIs yet.
So for now, I think we continue the treatment. Is she a candidate for TLE? One tablet?
Reduced pill burden.
Why isn't she a candidate? I know she's less than 35 kg, but she's 10 years old.
The weight is not okay.
The weight.
The weight is...
Okay, so anyway, the recommendation is that you keep her on the same regime. However, if your viral load suggests failure, you may have to look into issues of adherence. And if at all you decide to change this regimen, you are better off changing all of it to not do a sequential monotherapy. Any other comments about this case? Should we go to TLD transition?
Chilenje.
Oh, ma'am.
That's the question. Okay. TB resistance can be transmitted or acquired. This patient, despite being on isoniazid prevention, did develop TB. Can we think about any TB resistance, though there is no resistance to rifampicin?
Dr. Sibile wants to answer that.
Okay, maybe I had it's the same question, just to throw in the mix. How long do we intend to treat the TB? Is the TB up? And what medicines do we intend to use? Like the question has stated, we know that isoniazid resistance can be up to 10% in the country. Yeah. So we have a lot of TB experts here, I believe. So what would be our advice on how to treat this TB?
To treat it.
Yeah, I know the sputum's converted at 2 months and at 5 months, is it? But I feel there's still a risk, if the history is correct, that the patient developed TB whilst on isoniazid, knowing the higher rates of isoniazid resistance. My proposal would be probably I would continue the initiation or
RH continuation?
No, probably I would have continued without de-escalating up to maybe about 6 months in such a patient. But I think that since the de-escalation has already been done, now the patient is on Rifina. I don't know what my question is. What would be the solution? Getting sputums for culture are options that we have still. Yeah, we know. Yeah, but it's a question that I had also.
I know Dr. Member is part of the MDRTP committee. Do you want to comment on that? Dr. Sibila is saying, in view of the 10% INA resistance, and we have this child developing TB while on INH, that's the issue we've just gotten now. How should we move with the treatment? Should we treat as just any other TB?
So I'll just comment that, the child has already been on treatment like for 5 months, 6 months.
Yeah,
so if they were failing, probably would have caught it by 5 months. So that's my first point. Then my second point is that obviously INH resistance develops depending on the burden. So if you are going to be above 10 to the power 5, then the chances of you getting resistance is also high. This is a child who was diagnosed by gene expert and not by sputum. So again, that probably brings down the possibility of resistance. But having said that, it's always nice to make sure that there's no TB. So I have to do an LPA, and an LPA should not take more than a week for us to get the result and make a decision whether we need to continue or actually terminate at 6 months.
This is part because we're saying that the mother was sputum positive. Was she drug resistant or drug sensitive? She responded. So I think it's, in my opinion, very unlikely that she could have resistant TB if the mother, responded. And then the other question is, this child was started on INH when she was already symptomatic and she already had a contact. So were we correct in starting INH in the first place, or should we have started treatment? Because this sounds like it's a child who already had symptoms, and probably giving INH was inappropriate at that point because she had the contact and she had the symptoms. Because you'd normally start INH if you screen and doesn't have symptoms and doesn't have contact, then your INH will probably wait. So we are saying she developed TB while on INH. Probably she already had TB while we were putting her on INH, and probably shouldn't have put her on INH at that point because she was symptomatic. She had a contact. We should have started on TB treatment right from the start.
Okay, thank you very much, Dr. Kapasa. Dr. Mwango, I know you are here, and I specifically asked for you to assist us with this question. Can we transition this 10-year-old to TLD?
There's, I think, another view that we need to look at from the ART point of view. Children, especially when we're talking about changes in weight, need to be considered for timely dose adjustment. And I'd like to, verify that we adjusted the doses for the ART as the child was gaining weight. There's a tendency of when they're crossing a range for weight for dosing, that the patient will continue on a suboptimal dosage. And this is something that needs to be looked out for, especially when a child starts recovering, like in this case. So I would love to be reassured that the dose changes were done on time. That being said, if that was done properly, because that could be another reason why this child could be failing, and nothing to do with the TB, it's just the TB finding an opportunity where the dosing was poor and the child could not actually respond well. If we're going to consider TLD, we definitely need to have a viral load.
Okay. So one is the viral load. What about her age and sex? Do they matter? She's not childbearing.
Right now, I think this is a 10-year-old child. And I think if we do everything right and we consider her health as primary, we need to give her the best possible regimen. And for me, I feel TLD would be the best possible regimen. Should she become sexually active and we start looking at this possibility of getting pregnant, that's I think. Right now, I think if she's suppressed, then it's a possibility we can use dolutegravir. The only thing is that I would want to maintain the ABC3TC that she's been taking, so that we don't bring in the confusion of renal function. But if we can also do the creatinine clearance and we find that she's okay for that, then we can consider TLD proper. But baclofen, lamivudine, dolutegravir can be a very reasonable option for her as well.
Okay. Edgar, please keep sharing your screen. Thank you very much. You want to put up the didactic, but to continue discussing your case. Dr. Mango, that's to take you back. Are we transitioning 10-year-olds to TLD at the moment? Are we allowed to do that?
Yes.
What's our guideline? Oh, we are going as low as 10 years
right
now?
Now, the weight that we are looking at is 35 kg. But there's reasonable evidence that we can go as low as 25 kgs.
Okay, what about age?
Yeah,
I would be very cautious about tenofovir in a smaller child below the weight of 35.
Okay, yes, I think that's why you said the back of 3TC. No, thank you very much, Dr. Mwango, for that. There's concern about the use of tenofovir.
Yes, this is why I made emphasis on maintaining ABC3TC rather than going to TLD. So this is where we would now have to talk about giving dolutegravir with ABC3TC combination.
All right, so that's about
TLD. That's something that needs to be considered.
So the age range for our guideline is now 10 years?
We are more concerned about the weight than the age.
So it's over. Okay.
The
So 25
kg. 35 kgs.
35.
Yes,
okay.
35.
I think Dr.
But we can go as low as 25 based on the evidence that is available right now.
Okay, thank you, Dr. Mwango. Dr. Mlenga, I know you're scratching your head. You've been waiting long with your hand up. Please go ahead with your question. Dr. Mlenga, we are waiting on you now. Please unmute him. Dr. Mlenga, please go ahead with your contribution.
Thank you so much for. Thank you. I really agree to what Dr. Mwemba said, that I think we need to do LPA, but I think that this child may be doing well really. Okay. We shouldn't have seen any such response, I think, if there was a problem. Over the age, and I mean the TDF versus the DTG as well, it's the group of 12 years for TDF, for transition. Then for the DTG, you have to look at the age and also the weight. I know very well that soon, I think maybe on Thursday, Friday, we may be looking at transitioning or having the standalone 10 milligrams and 20 milligrams, 25 milligrams, and 35 milligrams as well of the DTG for the children. But you need those ones who need to be with ABC as well. So we'll be bringing DTG for combination, but you cannot use with TDF.
Okay. Thank you very much, Dr. Mwemba. Dr. Mlenga, we are now, I think the emphasis is that we need to pay attention to both drugs, isn't it? You have the dolutegravir that has its own caveat, and you have the TDF that has its own caveat, and they are coming as one pill, so we need to pay attention. And I think what Dr. Kapasa has said is very important when it comes to the use of INH. It's life-saving, prevents TB by treating latent TB, but it should not be given to children or adults who are symptomatic for TB, because now we are now getting worried that the child may have resistance. Though clinically it looks like she doesn't. We've received a recommendation that we need to do an LPA, so that means that we do a culture, then we LPA that if it's positive. So I think we are now ready. There's something. So now we are going into the didactic presentation.
Good afternoon once again.
The polling questions. As usual, we have a couple of questions that would like to go through just to assist with the teaching. I hope everyone can see those. Too small? I can see it.
Maybe you can read it.
So it's a multiple choice question on cotrimoxazole. Is it recommended for all HIV, TB co-infected children, regardless of their CD4 or clinical stage? Can it be stopped when a child is more than 2 years old and has a CD4 of more than 25? Should be given at birth to all HIV exposed infants. We are not seeing any answers coming up. Okay. Only one facility has answered. Can we all just answer those polling questions? Oh, okay. 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 The next question. The use of ethambutol in children, the risk of ethambutol toxicity is very high in children, even when used at the recommended doses. can be safely used at recommended doses in OH groups. Ethambutol is not recommended as the fourth drug in ATT for children. So the third question is recommended regimes for TB preventative treatment for latent TB: isoniazid, ethambutol, rifampicin alone, pyrazinamide. Thank you very much. I think we can go into that.
Okay, so I'll take you through the definition of TB, and we'll state the childhood TB as a public health problem and how to treat a child with TB HIV co-infection, when to start and stop cotrimoxazole prophylaxis, and how to prescribe the recommended ART regimen in a child with TB HIV co-infection, and some of the non-drug interactions, how to diagnose and manage iris, and what the key MDR highlights and preventative therapy are. Okay, so I'm sure we all know TB is caused by bacteria, Mycobacterium tuberculosis, and commonly it affects the lungs. That's a common presentation, but it can affect other organs, and then it will be termed as extrapulmonary TB. Commonly in children, we get pulmonary TB, but we do get extrapulmonary TB as well. It's transmitted through airborne. So if you have, for children, usually to be an adult around the child who may be coughing, or even when they are talking or singing, they are able to transmit those aerosols, and the child may inhale them and present with TB. We know that Zambia is among the 3 high-burden countries listed for TB, TB HIV, and MDR TB. And that's the overlap in terms of TB and TB HIV infection. We are still not in the category of MDR TB. So in terms of background, we are ranked 13th in terms of incidence as a country, and we are among the top 30 HIV TB burden countries of the world. We are notifying annually about 40,000 children who have TB, and that accounts for 6 to 8%. So looking at that, we are still below the required notification of about 10 to 15% of TB in children. And this is simply because of the challenges that we have in diagnosing TB in children. And it has been noted that we actually have a very high TB prevalence than was previously noted in the 2013-2014 prevalence survey. So in terms of specimen, it's very important that we endeavor to collect a specimen for diagnosing TB in children. And there are various ways that we can get, especially for younger children who are not able to expectorate. So for those children who are able to expectorate, yes, we could ask them to produce a sputum and we get it. But for younger children, there are methods that we can use: gastric lavage, nasopharyngeal aspirate, and sputum induction. Because it's important that we have a bacteriological confirmation of TB. Yes, we can use clinical, but it's always important to endeavor to make a bacteriological confirmation of TB. So those are some of the methods we can use to collect TB in children who are not able to expectorate. So in terms of making a diagnosis, I mean, obviously we have the typical presentation of a child who has TB. So we are talking about a chronic cough, and we usually were saying a cough of more than 2 weeks. The systemic symptoms: fever, night sweats, weight loss, a positive TB contact, and things like that. But we have to remember that there are other atypical symptoms that a child who has TB may have. And the commonest that we are seeing now is severe forms of pneumonia, especially children who are less than 1 year of age, or those who are HIV positive. So they won't have this chronicity of a recurrent cough or chronic cough. They'll come in with a cough of short duration, but they'll present as severe symptoms. So if we have a child presenting like that with a positive TB contact, we need to screen them for TB. And then also we are having children who are presenting with atypical wheezes. So normally we would associate a wheeze with asthma. And so if you have a child who's presenting with recurrent wheezes, who's not responding to bronchodilators and other medication, we have to think of TB, because you can have a hilar lymph node which is compressing on the airways and would cause a child to present with a wheeze, and especially if it's an asymmetrical wheeze. So we have to look at both the typical as well as the atypical ways that a child who has TB may present. So when we are looking at a child who's HIV negative, sorry, just go to the previous slide. So we have to consider, obviously, the symptoms, like I've said. And so if you do, the only way to confirm TB is when we have a bacteriological confirmation, isn't it? So we need to get sputum one way or the other and send it for smear or expert. If it comes out positive, then we'll confirm that we're dealing with a child who has TB. But we have to bear in mind that children have bacillary TB, and so we may not have the sputum to check, or even if we have, it may be of low yield and it may come out negative. So if they have a smear negative TB, or we are not able to do a sputum smear or gene expert, we have to look at the symptoms, we have to look at the contacts, and we have to look at the radiological investigation. If we have anything that suggests TB, then we'll make a presumptive diagnosis of TB. And if we do that in terms of we don't have TB contact, we are not able to do a smear, or it's smear negative, and the child, maybe responds to the cough with antibiotics, we may have to treat, send them home, and reevaluate them at a later stage. So that's for a child who's HIV negative. For a child who's HIV positive, besides the typical or atypical symptoms that they may have, if we are able to get a sputum and it's positive, we'll treat them as TB. If we get a smear negative, or we're not able to do a sputum for smear or gene expert, we have to rely on the contact. So if a child presents with symptoms and they have a contact, then we are going to treat them as TB. That's for a child who's HIV infected. But if they don't have a contact, but they have the symptoms and they have radiological evidence, or they have physical evidence that suggests that this may be TB, that child will treat as TB. And unless there's no symptomatology, physical examination, there's no TB contact, comes in with a chronic cough, obviously we have to rule out other causes of lung infection in children who have HIV. So the fact that they've come with a cough or the symptoms doesn't mean that they have TB. They may have other conditions because of their status. So in terms of treating for TB, we're using the fixed dose combination. We have, for children who are 25 kilos and below, we are using the 3 FDCs. and ethambutol as a standalone drug. Okay, so depending on what the weight band may be, you give the 3 FDCs and the corresponding number of tablets for the ethambutol, which is being given at 20 milligrams per kg. If a child is more than 25 kg, then we are going to use the adult formulation. But the adult formulation as well has got its own weight band. So we are not giving one. I mean, I've seen others, because it's an older child, they'll give one tablet of FDC. Again, we have to bear in mind the weight band, okay, and the different number of tablets that we are going to give depending on the weight. So in terms of treating a child who has TB and HIV co-infection, we've previously emphasized that TB takes priority, okay, over HIV. But I think you have to take a child as an individual. The reason we've been taking TB as a priority before is obviously we're looking at the pill burden that may affect adherence, and we want to see how the child is going to respond. And we have to bear in mind that both the ATT and the ART have their own side effects. And so the side effects may be worsened, and we may not be able to tease out which side effects is, which some of them overlap if we start them at the same time. So those are some of the reasons we were starting with TB in a child with made a diagnosis of HIV. And when you have a child who's you think is poorly responding to ATT, we have to go back and reevaluate and look at the adherence. As we had in the discussion, we have to look at some of the drug-to-drug interactions. We know that rifampicin interacts with nevirapine and interacts with lopinavir, ritonavir. So when we are seeing a poor response, we have to bear in mind the drug interactions. We have to also think of the other diagnosis. We may have made the wrong diagnosis. I've said that a child who has HIV infection may present with other lung problems other than TB. So we may make a diagnosis of TB and the child is not responding. We have to consider that we may have made a wrong diagnosis and look back. And we have to consider other concurrent opportunistic infections, ensure that if the child is malnourished, we are looking at the malnutrition as well. There may be malabsorption because of the chronic illness of the child. And indeed, it's possible that a child may have drug resistance TB, and we have to go back and reevaluate. Okay, so I've mentioned that when you are giving a child TB treatment who already is on ART, some of the drug interactions we get is with nevirapine or other protease inhibitors, and rifampicin reduces the plasma concentrations of these. And efavirenz containing regimen is preferred in a child who you have who may have TB and they are on ART. So if they are on other ART, we have to consider giving efavirenz or super boosted ritonavir, super ritonavir boosted lopinavir at the time that you are giving ATT, and then you switch back when they finish the ATT to their previous ART regimen that they may have been on. So if we have a child who has TB and is HIV and they are less than 3 months, then we have to look to the expert infectious diseases colleagues to guide us on which medications we may need to give. So we're talking about dolutegravir, and if you have a child who's on DTG and is on ATT, we have to double the dose. So instead of giving it once a day, you give it twice a day while they are on ATT, and you revert back once they've completed the ATT. And it's already been mentioned that we have to be cautious in children of childbearing age, because we know that it causes neurotube defects if the child or the adolescent had to get pregnant. So pediatric patients who are less than 3 months who are 3 months to 5 years of age and they have TB and HIV co-infection, then you have to put them on efavirenz during the period that they are on ATT. We have to make sure that we are doing viral loads at the time that we are starting the ATT and at the time that we have completed, as a way to monitor adherence and response to treatment. So when we are talking about IRIS, so IRIS is a response to a child who's had severe immunosuppression, and you start them on ART, and this comes about as a result of the severe immunosuppression, and it will occur between 6 and 8 weeks. So what it does is that because you have started the ART, the immunity starts reconstituting itself. So you have unmasking of the symptoms where the child may have had TB and it was silent because they were very immunosuppressed. They couldn't mount up any response, so they were not presenting with any symptoms. And once you start and the immunity starts to get better, they start manifesting with those symptoms that were quiet. And then you also get a paradoxical response because you are saying that this child was severely immunosuppressed and they had an infection. You expect that because the immunity is getting better, they should start getting better, but the opposite happens. Okay, so that's a paradoxical response. So when we have a child who have recently started on ART and was severely immunosuppressed, we have to rule out TB, first of all, in the first place. And we have to make sure that if they had TB and we're treating, is it that they have failed on the TB, or do they have drug resistance, or were they non-adherent, or was there malabsorption? So I think the message here is that don't take IRIS literally as IRIS. We have to make sure that we are not missing any of those conditions. And we have to also assess and investigate for other HIV-related conditions. And in terms of management, usually it depends on the severity. If it's a mild IRIS, you monitor and you may give non-steroidal anti-inflammatory drugs. And if it's a moderate or severe, then the child may need hospitalization, and you give steroids at 0.1 to 1 milligram per kg per day for between 5 to 10 days. So for MDR, I've already mentioned that children have palsy bacilli, and so we may not get a bacteriological confirmation of TB, but it's always important because that's the only way we'll know whether this child has MDR is when we've had a sputum to examine. And so treatment of MDR should be commenced in children if we have a confirmed MDR by DST or by gene expert if we have rifampicin resistance, or if we have a child who has a smear positive sputum with a known or confirmed MDR contact. So I think it still boils down to us still making an effort to get a sputum for examination. We can still make a probable diagnosis of MDR TB in a child with unconfirmed DST who's not responding to standard TB therapy and has a known MDR TB contact. Okay, so these are just some of the x-rays that we normally get in a child who has TB. So you may get hilar lymph nodes, and like I said, sometimes they may compress on the trachea and cause a wheeze. You may get a miliary picture, or you may get a consolidation. So there are various ways that radiologically a child who has TB may present. Sometimes you actually may get a clear picture with nothing radiologically. So in summary, diagnosing children with TB requires a good history and a thorough examination. It is not difficult, as previously perceived, to make a diagnosis. We just require more zeal in terms of making or getting a sputum in that child we suspect to have TB. The treatment principles are the same as adults. We're giving fixed dose combination, but we are looking at the weight for these children as we give the treatment. And we have to remember that cotrimoxazole as well as IPT is essential component of HIV care in a child who has TB. Thank you.
Thank you very much, Dr. Kapasa. I think we'll now have a look at the polling questions. Edgar, we want to thank you so much for your case. It brought out a lot of the pills, and Dr. Kapasa has talked about most of those things. We will have a look at the polling again. Okay.
Yeah, so ethambutol is safe to use in children of all age groups as long as you are using it based on the correct dose and you strictly give it for the intensive phase of 2 months. There are negligible toxicity that is associated with ethambutol, and so we need to add it for children who are less than 25 kilos if we are giving them fixed dose combination. Because those ones, the 3-FDC, don't have ethambutol, but ethambutol is now recommended for all age groups of children. So it's safe to give. So yeah, so in terms of preventative therapy, yes, it is isoniazid standalone that is recommended. However, there are other regimens that we can use, a combination of rifampicin and isoniazid, as well as rifapentin and isoniazid. But I think we haven't yet, I stand to be corrected, we haven't yet adopted either of those two. We are still using the isoniazid prophylaxis standalone for preventative therapy.
We done? Oh, okay. Thank you very much, Dr. Kapasa. That was so riveting. Okay. I know I've seen Dr. Muya walking. Just to put you on the spot. What is your comment? Oh, okay. On using a Abacava 600, 3TC 150, and the Favirenz. Because I think issues, this child, people are concerned about the pill burden, how the child is taking the pills. How do we make her life easier? If she's suppressed, are we allowed to give her that? Would you like to comment on Abacava?
Once a day.
Yes.
Okay, let's put it this way. So it's not in our guidelines, but what we have seen at the center here is that we are giving once a day and it's working very well. So instead of 300 twice a day, we are giving it 600 for Abacava once a day and Lamivudine 300 once a day. It's acceptable in literature and a lot of studies have been done and it's doing very well. I know in our guidelines it's not there, but it's, I must emphasize that, but it's a very, something that's acceptable and it's working very well in our center.
Okay, thank you very much, Dr.
Actually, I think even in the new guidelines, I've seen somewhere where there's a note that if patient is well suppressed,
okay,
then you can go to once daily.
So if Edgar does a viral load and the child is suppressed, he can give this child drugs once a day by combining the Abacava and the 3TC.
Yes.
Oh, thank you very much, Dr. Muya. Lenje, please go ahead.
What is the duration of the protective effect of preventive TB therapy?
That's a very good question. What's the duration of, how long will isoniazid protect you to take it? Any volunteers on INH prophylaxis? Any hands? Okay.
Yeah.
So, okay, yes, go ahead, Dr. Muya.
The last I did was about 3 years. But only about 3 years, I think, if I guess correctly.
Yes.
Yeah, but the only challenge here is that you must be aware that, you know, we're in a TB high burden area. So I may finish my prophylaxis, and again, my next door neighbor or my family has another cough of TB sputum positive. So there again, it means it won't be protective.
Thank you very much, Dr. Muya.
It's really high exposure, but supposed to protect you for that long.
For that long. So apparently INH prophylaxis therapy has been found to be very effective in low prevalence areas like Europe. You come from Zambia, you go to Europe, it will protect you because there's no TB. In our environment, we have a lot of TB. So give it a caveat of 3 years, though it's limited. So this is an area of research that's still being explored, and that's why we need to do contact tracing. We need to go in the community and pick out the other TBs. Because if a child goes back where there's TB, they'll get TB again. So it only lasts 2 to 3 years. Thank you very much, Dr. Muya. Hi, Doug, would you? Dr. Mwemba. Please go ahead, Dr. Mwemba.
It's okay.
Okay.
So I think that someone has already mentioned it. I think you mentioned it, Dr. Poloshi, that I think that even in Zambia, our emphasis is that we should do case findings. If we're going to bring down the TB load, it means that when we do IPT, it will be effective. But as long as we're going to leave those patients that are symptomatic out there, it means once we do ITP, then they'll go back and get infected. So I think that all of us, we need to get those cases and make sure that they are treated. Then the load will be low, and then IPT will work better.
Okay, so IPT will work better if we get the prevalence in our communities low. I'm not sure, I've seen Doug. Doug, do you have any comments before we wrap up? It's been a very...
Hi, I think it's been a really good discussion. And just to reiterate a couple of points, a lot of really good points have been made. And one is that, a rising CD4 does not necessarily mean you're not failing. And incident tuberculosis doesn't necessarily mean that you are failing. Perfectly normal 10-year-olds walk in the door with tuberculosis. So, the point that we really need a viral load to know whether or not this child is failing. We just don't know. There's nothing to tell us. Otherwise, and I think Dr. Dinmala, as she said, at this point, we don't have any reason to change therapy. With respect to the antiretrovirals and tenofovir, the issue is not age, it's weight. Tenofovir is labeled for use down to 2 years of age. And there's an infant preparation and so on. The issue is it doesn't matter who it is, you never want to overdose tenofovir. You always have to look at the creatinine. You always have to look at the weight. You have to use the right dosage. This child actually, if you calculate it, she should be on 216 milligrams or thereabouts of tenofovir. So she unfortunately is kind of halfway in between a 150 milligram tablet, which you have, and 300 milligrams. But she's kind of stuck in the middle. So, unless you are splitting tablets and, giving her 1.5 tablets a day or something, it'd be kind of difficult to give her tenofovir in the right dose. But I guess if you had to do that, you could do something like that. The key is just never overdose tenofovir. So I think those are really the main points. The question of isoniazid resistance, kind of raises its head because of the IPT history. And I think we just have to leave that in the back of our mind. Our TB treatment regimens are designed to usually work if you have isoniazid therapy. That's why we start with 4 drugs. We'll see. Obviously, her bacteriologic response and clinical response is very encouraging here. We'll have to see. But again, I can't see doing anything different other than what is being done right now.
Thank you, Doug, for that. I really liked your summary. Dr. Mlenga, would you like to just say something before we close? We can't hear you.
Yeah, we have pediatricians on the board there. I think what we'd like to hear as a program as well is just by email recommendations of use of DTG in those who are less than 40 kg, so that we can make a decision on which formulations we can get for children. If we can get that in 2 days, that would be fine. Then over the to 7 years protection if in terms of isoniazid, if someone has been on IPT.
Okay, thank you very much. So up to 7 years protection if you are in a low prevalence area. Chilenge, Nangongwe has a hand up. First, welcome. Please introduce yourselves. You've always joined us and we haven't heard you. We will allow this question, then move on to Chilenge. Nangongwe, please go ahead.
Thank you very much. I would like to find out, I heard from
oh, wow. Sorry, you are really breaking. Are you able to move?
We are saying is giving a backup acid 600 milligrams.
Yes, that, he did say that.
Find out
No, I can't hear.
Yeah. I'm so sorry, Nangongwe. We are hearing you in bits and pieces. They can't tell. Are you able to switch off your visuals, keep your audio, and let's try that, Nangongwe? Because we can't hear you at all now. Are you able to switch off your video, keep your audio on, and let's try that? Sounds definitely for you, Dr. Muya.
I don't know the question.
Okay. Or you can put something in the chat. Dr. Muya is very ready for that question. Chilenge, please go ahead with...
Looking at how difficult TB diagnosis is among HIV-infected children, why can't we just give a full TB treatment to all HIV-infected children that get TB infection? I do believe that we do miss a lot of TB cases among children. Thanks.
Okay. So, Dr. Mwemba, there's a suggestion. Why can't we? Is Dr. Zulu in? He's the one who deals with a lot of these ART, HIV, TB diagnosis. Dr. Zulu, would you like to comment? Why can't we just give all kiddies TB drugs as we are initiating it, because we are missing a good number of our TBs? Why are we missing it?
So I think part of it is already been mentioned, the challenges, I think, in terms of diagnosis. So that is one. But also there is the issue in terms of public health, the cost implications of that. But not just that, also the client implications, their toxicities related to these drugs, and you cannot just give them. So the emphasis would be probably trying to utilize more of the diagnostic tools that we have to try and pick out more of the cases, like Dr. Member has already alluded to, than trying to do a mass drug administration of ATT.
Thank you very much, Dr. Zulu. So certain things have to be in place before you.
Dr. Muya wants to.
Yes, Dr. Muya.
So just to answer his question, pediatric TB per se is mainly based on clinical grounds because of the various factors and challenges that are involved in making a diagnosis. So it's acceptable to make a clinical diagnosis and start on treatment. So there must be a very high index of suspicion. Once you have somebody with the TB contact, fevers, not responding to antibiotics, weight loss, all those things are indication that something is not going right. So index of suspicion must be very high that this could be TB. So that way, then you'll be able to justify and say, well, I'm giving you drugs. Not giving everybody, but again, that would be wrong.
So thank you very much for your suggestion, but it's been suggested that we actually just raise our index of suspicion in children with TB. So we always screen these children for TB. I think now we can close the session.
There was a question of when you give ATT for below 3 months, which ARVs to give?
Okay.
Yeah.
Please take it.
So there we give triple nuke. We give, for example, lamivudine and ABC. So you give what we call triple nuke.
For those below 3 months of age, we give triple nukes.
Yes.
All of them from the same group. Things like AZT3TC with abacavir.
Yes. And
we will reconstitute the regime when the child is at the appropriate age or they've finished the ATT.
Just another one. Again, super boosting also is a challenge for us because the ritonavir is not readily available. So what we do is we double dose. Although it's a lot of controversy surrounding double dose of lopinavir, but it's a better demo with double dose of lopinavir if you want to eat it. And that's what is in our guidelines.
To find out, following that, Dr. Folosh, is there a way that we can supplement the ritonavir in our, instead of them double boost?
Because double boosting is when you give the ritonavir. Super boosting is when you give the ritonavir. So is there a way we can get the ritonavir on its own?
Yes.
I think that's for Dr. Mlenga, because we sometimes do it in adults. In adults, we tend to just give double dose. Sometimes we end up super boosting, especially if somebody has got diarrhea. Dr. Sivile, go ahead, but I need to wrap up. And
I think it's a response to what Dr. Moya was saying. Maybe Dr. Mlenga can comment on this.
And ritonavir.
Is raltegravir a good choice? We know that you can easily double dose it, probably, and sometimes you don't have to. And in children now, it's approved up to from birth. Raltegravir.
Okay, so Dr. Mlenga will take. I know the pediatricians are saying no to raltegravir because there's been a lot of breakthrough viremia with raltegravir, and once you lose your raltegravir, it may impact your DTG. I'll let Dr. Mlenga say something.
Apparently, Dr. Folosh, I feel that it's easier to start with raltegravir than dolutegravir, as opposed to DTG and raltegravir, looking at the mutation pathways. But also, even as we move to DTG, we should not be carried away that DTG may be the answer for TB. We have no trials so far on the DTG dosing with rifampin in children. We have for adults. So we still have issues to go around in the children. Yes, we can get lopinavir. I think Dr. Member ritonavir was asking. It's as well. And also logistic management, it would be a nightmare.
Yeah, so thank you very much, Dr. Mlenga. So ritonavir would be a logistic nightmare. We should always consider raltegravir then dolutegravir, but there's a lot of research that needs to be done. And I think with that said, we want to really thank Edgar. Your case was very good. It helped us learn a lot, and we had a lot of parents. Next week, we have Dr. Mpeta presenting on screening for HIV-positive patients and prophylaxis. I think the facilitation will be by NOMSA with Dr. Candio. Thank you very much. And there are some announcements that should be. You were very good.
While we still have everyone on, I must say that this has been a very educative session, and thank you all for joining in. Just a couple of announcements. I will ask Chatonda, please put up the slide. I'm sure this has been a very, very interesting session, but we would also want to mention that if you want to go through the session one more time, and or someone missed, you can still have an opportunity to go through the same session if you are able to join in on YouTube. We'll share the link with you, and you'll have an opportunity to go through the session. But I also want to mention that you can also have additional resources. We have additional resources. We do have some e-learning courses, and we have the link up there. You can access HIV-TB courses on this link, www.learnerhealth.zambia.org. And this is just to consolidate your knowledge. I'm sure you'd want to go back and consolidate some of the issues that Dr. Kapata has just been discussing with us. And then finally, I think Dr. Sombo has mentioned that let's look forward to the next session on Monday. Please join in, and we have a very interesting topic. I'm sure you look forward to joining in next week. And those of us that have attended the session, we want to take, please send in your attendance register. We just want to capture everyone that is attending the sessions. Thank you so much for joining in. And we'd also want to hear your feedback from the spokes, how this is going on. We can get emails or call us so that we get better.
Thank you very much, Nomsa. Thank you very much, everyone, for turning up. And it's a wrap. Thank you.